Hello, everybody, and welcome to the Hughes Clues Structural, Infectious, and Inflammatory Disorders, Part 2. When we stopped, or when we finished Part 1, we talked about a 60-year-old or an elderly man actually, that chose to have open chest surgery for aortic valve replacement. But let's pretend in this scenario that instead of a patient that's elderly, now we have a patient that's about 60. And he's gainfully employed, but he doesn't have benefits. So, in other words, if he undergoes an open chest surgery, he's going to have to pay for this expensive surgery and then have about 6 weeks off without pay. So that might be a very stress or burdensome thing for him and his family. So what alternative treatment options for value disorders are available? And if he chooses to do an alternative treatment option, are there long-term health risks? So there is conservative or medical management for valve problems. It can either be because the patient refuses to do it or because the valve is just not that bad, and so medical management or conservative management is totally appropriate. So what are the goals of medical management care? Well, we want to reduce or prevent the patient from having heart failure exacerbations. We want to ensure that respiratory failure doesn't occur from pulmonary edema. We want to prevent dysrhythmias, or at the very least treat the dysrhythmia, and then there's the risk of thromboembolism and recurrent endocarditis. So what are the long-term health risks? So let's really go back to that other patient that we had, the elderly patient, and let's look again at the results of the echocardiogram. So it was described that there was a severe impairment of blood flow as blood is ejected through the aortic valve. So what does that mean? Well, when you have this narrow doorway, when you have this stenotic aortic valve, the left ventricle has to use a lot more energy and force to push blood out. And over time, as this occurs, then this creates a much greater workload to the left ventricle. And over amount of time, then the left ventricular muscle can become enlarged, just like if you went to work out and lifted weights for quite some time, your muscles are going to get bigger. Well, it's the same in the left ventricle. Now, this is not a good thing in heart scenario, because what happens is the shape of the ventricle changes. It becomes a different shape, so it's a lot less effective or efficient in ejecting blood. And if you'll notice that thickened muscle has created less space for blood to be filling. So that means less space is present here in the ventricle, which means less amount of blood is going out. So the cardiac output goes down. And so that's why the individual had a poor ejection fraction. So what is this termed? Whenever the heart muscle thickens, it's termed cardiomyopathy, and because it's acquired, or it has occurred because of a problem with the aortic valve, we've got acquired cardiomyopathy. Now, in your course notes, there's a lot of different types of cardiomyopathies, and there's different causes. I'm not going to go into all of those because I don't think you really need to know that. I think what's important is that you need to recognize that with cardiomyopathy, the heart is less efficient, and therefore the cardiac output goes down. So simply put, the heart failure can develop. And in our subject, heart failure has already developed because you have a patient who presented with a decrease in ejection fraction. So what is heart failure? That really is probably where you need to focus on the complications of cardiomyopathy. So when we talk about heart failure, it's an abnormal cardiac condition which results in an impaired ability of the ventricle to fill. So it could be a filling problem, which would be termed as diastolic heart failure, or it can be termed a problem with the ability of the ventricle to eject blood, and then we would have systolic heart failure. Now, most of you guys are probably familiar with just the term heart failure, and you won't really have to recognize whether it's diastolic or systolic heart failure. You just need to be aware that those terms exist, because you probably will see them in physicians' notes. Now, there's several different causes of heart failure. If the individual has had ischemia, such as and an infarction, such as from a myocardial infarction, infection, then they can develop heart failure, cardiomyopathy, which is what our topic is now. Untreated hypertension can cause heart failure, structural cardiac disorders, and a whole host of other problems. The bottom line is heart failure is where your focus of treatment needs, and that the basic definition of heart failure is the inability of the ventricle to pump blood forward. So what's the medical management for a patient with heart failure? Before I talk about medical management, I really want to go with what's the pathophysiology of heart failure, because the medical management won't make sense unless you remember or know the pathophysiology. So when we start here with this black box, we see that anything can impair the heart's ability to pump. Lots of different things. It can be a structural problem such as cardiomyopathy. It can be an MI. Regardless, the bottom line is the heart is unable to pump blood forward, and that will lead to a decrease in cardiac output. So that's the first thing that happens. Cardiac output goes down. And there's the kidney is the organ system that really is one of the first organs to gripe and moan and complain, because the kidney is like, yo, where's my blood? If you want me to filter blood, I can't unless you give me the cardiac output. So with the decrease in cardiac output, the RAS is activated. Now, the sympathetic nervous system is actually activated first because that's from the baroreceptors in the aorta. But no matter, both of these things are activated when the cardiac output goes down. The sympathetic nervous system is activated, and the RAS, the renin-angiotensin and aldosterone system, is activated. So let's talk about each one. With the sympathetic nervous system, that's your fight or flight. So that's your beta stimulation that occurs. And what the beta stimulation does is it makes the heart beat faster, but it also makes it beat stronger. In other words, it's like a bear is standing behind you. You want to get the heck out of Dodge, and so to do that, your heart has to beat stronger and it has to beat faster. All right, well, that's a good thing if you're running from a bear, but if your heart's weak, then that's a problem, because whenever the heart has to beat stronger and faster, that's going to increase the oxygen demand, and it's going to make more work for the heart. That's the downside. That's the bad thing. Now let's talk about the RAS. What does RAS do? Well, we know that renin becomes ultimately angiotensin II. And angiotensin II will cause vasoconstriction. So think about that aorta being markedly vasoconstricted. That also will make the workload increase. And then on top of the vasoconstriction, the aldosterone gets retained or gets secreted, and when aldosterone is secreted, that's the second A in the RAS, then sodium, the kidney is told to hold on to sodium, and that will cause water retention. And that's the reason for the fluid volume overload that is most commonly or almost always present with heart failure patients. So now you have kind of this threefold mechanism where you have the rapid heart rate, the vasoconstriction, and sodium retention and water retention, and that basically just totally stresses out this weak heart. And when you have all of these demands here, and you have this heart that was already weak to begin with, and now you're making even more demands on it, then the heart begins to fail even more, and the cardiac output goes down, and then all of this keeps going and going and going. And it's just a cycle that never ends. So therefore, your patient, when we talk about what signs and symptoms would you be looking for, you're going to be looking for heart failure signs and symptoms, and they fall under two headings. The first is that the cardiac output goes down. So you're going to see signs and symptoms of decreased or poor perfusion. This is very important that you get this and that you're familiar with it and be attuned to it. And then the second signs and symptoms is that congestion, because you have all of this fluid volume overload, and so therefore you have signs and symptoms of congestion. Now, the signs and symptoms of congestion are going to be different depending on which side of the heart is failing. And so probably in patho, you might recall that we divided it into left-sided and then right-sided heart failure. And I'm not going to go over that because this course doesn't really differentiate between right and left. We just call it heart failure because we kind of make an assumption that the whole heart's failing, both right and left. But however, I'm not about getting you through this course only. You do have to get through ATI and you do have to get through NCLEX, your licensure exam, and it's a hot topic. So just kind of keep this in your notes so that you can look at it again for ATI and NCLEX. So we go back to what the problem is and how do we manage the problem. So in other words, when we look at this scenario, we see that the sympathetic nervous system has to be shut off. And the sympathetic nervous system shut off is going to be by the use of a beta blocker, a medication beta blocker. And we know that all beta blockers end in OL, and so again, you should be familiar that a beta blocker will cut off that part of the problem. And then we also want to cut off the RAS system, and so there's a couple of medications that cut off the RAS. These are the ACE inhibitors. ACEI is ACE inhibitors, vasodilators to counteract the vasoconstriction, and aldolate will counteract the sodium and water retention. So again, we want to stop the cycle, and that's how we do medical management or medical maintenance. A little bit more detail on this slide. I don't think it's necessary that you know all of this detail, but I would say to you that you do need to recognize that drugs end in IL. Those are the ACE inhibitors. Beta blockers are OL. Vasodilators, calcium channel blockers, end in PINE. Now this one you might not be familiar with. This is a drug called Bidil. It's an isorbididinite, whatever, that one. And hydralazine, which you probably are familiar with, is a diuretic. And this is for African Americans. AA is African Americans. So this is a very interesting research study that was done by a cardiologist on the Black or African American population, and they've noticed that it's not all heart failure is not the same in all races. So I found that to be interesting. And then, of course, positive inotropes there. And then there's a new class of drugs. It's called the neprilysin inhibitors, and I've got information here. You're not going to be tested on this, but this is kind of an interesting thing so that you stay tuned in all the latest and greatest. If you go and look at your advertising, the sun will come out in tomorrow. That's the name of the drug, Entresto. I'll talk about BNP because that's what this drug is all about later in this presentation if you don't remember BNP. So let's go back to how do we do the medical management or conservative approach with valvular disorders. We talked about heart failure treatment and the respiratory failure as it relates to the pulmonary edema from the heart failure congestion. We know that if the patient has dysrhythmias, we're going to treat with antiarrhythmics. Thromboembolism risk, we're going to do anticoagulants, and again, that would also be a double hit. If the patient has AFib, then anticoagulants are also indicated. And then with infective carditis, this was in two places in the notes, so note that if the patient has a valve replaced or whether it's a valve that is bad, that we're just doing medical management, there is always a concern about the flaking off or the vegetations and microbes. And so anytime a patient's going to have a dental visit, then they have to have prophylactic antibiotics. Describe the nursing management of patients with heart failure. And this shouldn't be any new information. I'm not going to go into a whole lot of detail with this because you probably know this information. Go ahead and pause the recording and look at all of these different things. I do want to point out that remember that with the aldosterone or RAS activation and the fact that aldosterone is present, that there is a lot of, or there is sodium that is being retained by the kidneys, and therefore we do want to do a low sodium diet, and these patients need to watch their weight gain because 1 pound of weight is equal to 1 liter of fluids. And yeah, sure, maybe in a day they've had a lot of fun things to eat, but if it's over 1 day they've gained 2 kilograms, 2 kilograms is equal to 1 liter of water. So you really want to have the patient watch for that. Again, we always have to be careful about if they have chest pain, what's the cause, medication, and follow-up visits so that the patient does not develop ventricular dysfunction. I hope this has been helpful. If you have any questions, email me.